My name is Rachel Ballard, and I'm a child psychiatrist and pediatrician in the Pritzker Department of Psychiatry and Behavioral Health at Ann and Robert H. Lurie Children's Hospital of Chicago. Our next speaker is Lisa M. Horowitz, PhD, MPH, of the National Institutes of Mental Health. Dr. Horowitz is the lead PI for the NIMH on several projects, but for our purposes, the most important is her work in developing a suicide risk screening instrument for medical patients. Dr. Horowitz?
Dr. Horowitz, can you please unmute?
Okay, sorry about that. Well, thank you for that introduction, and thank you so much, Dr. Moore, for inviting me to participate. It's such a privilege to be here today to speak about this really important public health crisis that we have. And it's just, you're my favorite audience to speak with because you're so diverse in disciplines. And I think that's really important because there's hundreds of you in this seminar, in this conference, and every single one of you actually could make a difference in saving a life by starting the conversation. And that's what I'm here to talk about, is how do we ask these questions? How do we screen? Okay, so before I start, because I work for the government, I have to put this slide up, and I don't have any financial conflicts to disclose. So I always like to start my talks with my take-home message and my last slide. And so really what I'm going to tell you today is that it is feasible to screen all medical and psychiatric patients for suicide risk in medical settings. And the best way to do that is to ask directly. And that clinicians really need population-specific and site-specific, validated, tested screening tools to do this. And I'm going to talk a little bit about a clinical 3-tiered pathway, and that all patients who are having suicidal thoughts should really be discharged with safety plans, resources like the National Suicide Lifeline, Crisis Text Line, and then lethal means safety and counseling, as our speakers have spoken about already this morning. So without repeating things that Dr. Hogan spoke about, I just want to show you again suicide is the 10th leading cause of death. But I want to focus on kids a little bit more. And it is the second leading cause of death for 10 to 24-year-olds. And if we look at 2018, what we see is death among 10 to 24-year-olds have actually decreased. So number of deaths have gotten less, but the percentage of those deaths from suicide has increased. And so over a quarter of our young people who die by suicide. As you can see, this graph looks a lot like the adult graph, and it just keeps creeping up. We haven't made a dent in the suicide rate in over 65 years. And in fact, more young people die from suicide than these 7 other leading medical causes combined. So if we look at some of the CDC data, we see that if you look at number of deaths, kids actually have, the number of kids that die by suicide is lesser, but if you look at the rates, they're actually higher. And these rates are increasing. So these are males, and this is comparing a period from 1999 to 2017, 99 in yellow, 2017 in green. But look at the females, and again, look at the kids, and these rates are just staggering numbers of increase. And then look at the 10 to 14-year-old age group of girls. This rate increased 225% since 1999. And if we look by ethnicity, and I know Dr. Benton tomorrow is going to talk a lot more about racial disparities, but we can see that American Indians and Alaska Natives have the highest rate. This is the black line right here, and these are young people. They have the highest rate of suicide than any other race or ethnicity. So younger children under the age of 12, there's a myth that younger children don't die by suicide, but actually younger children do plan, attempt, and die by suicide. And we have some studies showing that, and in fact, one of our studies from the emergency department showed that 29% of the preteens in our study were at risk for suicide. Then there was an important study that came out in JAMA Pediatrics that looked at the suicide rate over time since 2007 and saw that the rates were doubling for kids presenting with suicide attempts and suicide ideation. And when you look at those numbers, you see that 43%, so almost half of those kids that are presenting are kids between the ages of 5 and 11 years old. I was fortunate enough to be part of a study with Dr. Jeffrey Bridge from Nationwide Children's, and we looked at the suicide rate of kids under 12. And when you looked over time, again, from 93 to 2012, it looked like it was stable. But when you parsed it out by race, we saw this significant racial disparity with the rates decreasing for white children and increasing for Black children. We don't know the reasons why, and so a lot more study has to, a lot more research needs to be done. But just to speak briefly about the racial disparity, this is, you see that young Black children have higher rates of suicide than white children, but that the trend reverses at age 13, and then actually white teenagers have higher rates of suicide than Black teenagers. Now, more recently, Black teenagers have the highest rate of increase in suicide than any other racial group. And so again, Dr. Benton's going to talk about that tomorrow. So suicide's still a relatively rare event. What's more common than suicide is suicidal behavior and suicidal ideation. So when you look at the Youth Risk Behavior Survey, which is a survey of tens of thousands of kids in high schools across the country, and these are your average high school students. So this is a self-report asking your average high school student, have you tried to kill yourself in the past year? Almost 9% have self-reported that they have. And 18%, 0.8, have reported that they seriously considered killing themselves. And again, that's your average high school student. So those numbers are just staggering. So these are the risk factors for suicide. And I'm not going to go through all of them, but I highlighted the most potent ones. And so previous attempt, that's our biggest predictor of future attempt. So we have a saying in psychology, best predictor of future behavior is past behavior. This is absolutely true for suicide. Anyone who's tried to kill themselves in the past is more likely to kill themselves in the future. Mental illness. So 90% of people who die by suicide have a diagnosable mental illness. For kids, it's a little less. It's somewhere between 40 and 60%. So that leaves a lot of people not diagnosed with a mental illness that also are at risk for suicide. And then medical illness, I put that in red at the bottom. And this is a risk factor that's often overlooked, but an important one to pay attention to. Now, most people who have these risk factors are not going to die by suicide because they're risk factors. And in fact, if we take the analogy, if you were a triage nurse in an emergency department and someone came in with the risk factors for a heart attack, let's say they had a family history of heart attack, they had high cholesterol, high blood pressure, they were a smoker, they were obese. Those are all risk factors for heart attacks. But if they walked up to your triage desk, you would not think they were having a heart attack. But if they came in with warning signs for a heart attack, right? Let's say they had terrible chest pain and they were clutching their chest and they were sweating profusely, then you might think they're having a heart attack because those are warning signs. And think of the same for suicide. So there's risk factors and there's warning signs. So the first warning sign, it's going to seem obvious, but it's one that people often don't take seriously. Someone talking about wanting to die or kill themselves. And especially for kids, often the talk is not taken seriously. In that study of kids who died by suicide under 12, what we found was a third of them had voiced their suicidal ideation to an adult, which, you know, is a tremendous opportunity for capture and rescue, right? But sometimes we don't take it seriously. Or looking for a way to kill oneself. These are other warning signs: feeling hopeless, trapped, or like you're a burden, increasing the use of alcohol or drugs, acting anxious or agitated, or the signs of depression, sleeping too little or too much, withdrawing, feeling isolated, or severe mood swings. These are all warning signs that someone might be at imminent risk for suicide. All right, so I just laid some very heavy, sobering statistics on you about suicide. But this presentation is actually a presentation of hope and action, because there are things we can do to prevent suicide. So I'm part of a research group at the National Institute of Mental Health that asks, can we save lives by screening for suicide risk in all these different medical settings? And I'm hoping that by the end of my presentation to convince you that the answer to that is yes. Okay, so we just heard this wonderful presentation from Gina Malfeo-Martin and Stacy Paul about the Joint Commission. What we find is hospital-based suicides are rare, but they're devastating events, and they are in the top 5 sentinel events reported to the Joint Commission. But as Gina told us, those are not all happening on the behavioral health units, that even maybe somewhere around 14% are happening in non-behavioral health units, places like the emergency department, the ICU, the cancer units, the med-surg units. And so one of the best things to ever happen to translating research into practice was the Joint Commission Sentinel Event Alert in 2016 that actually didn't mandate, but put out a recommendation that hospitals should screen all medical patients for suicide risk. And when you look at the suicides that have occurred in hospitals, and you do root cause analysis, the number one root cause is actually lack of assessment. And so under detection is just a terrible problem. And in fact, if you look at death registry studies, the majority of people who die by suicide have visited the healthcare setting months before their death, sometimes weeks. And this is true for both adults and kids. And so just here are some of the places they've visited. Now, the problem is that most people who go to a medical setting present with somatic complaints, right? Physical complaints. And if someone doesn't ask them directly, are you thinking of killing yourself? They most likely are not going to talk about it. So the majority of suicide attempters just pass through the medical setting undetected because the majority of medical settings don't screen for suicide risk. So this is one of my favorite New Yorker cartoons. It's an elephant in psychoanalysis. And I put this up here because we believe that suicide risk is the elephant in the room. And if we could just give healthcare providers the right questions to ask, then they could detect this suicide risk and bridge the patient to mental health care. So our research group asked, what are these valid questions that nurses and physicians can use to screen medical patients for suicide risk? Now, before I get into that, I just want to talk about the difference between a screening and an assessment, because this is really important. A screening is a very brief way to just flag someone who needs further evaluation. An assessment is a much more comprehensive evaluation. It confirms the risk, it guides the next steps. But these two things are different things, and I'm going to talk a little bit about that. So we launched this study, the Ask Suicide Screening Questions Study, the ASQ. We used 3 hospitals in Boston, Washington, and Columbus, Ohio. And what we did was we oversampled medical patients and we infused the sample with psychiatric patients because we wanted to make sure, we didn't know what we were going to find. We wanted to make sure there were kids in the sample who would have suicidal ideation. And we used kids 10 to 21 years. And so the way you create a screening tool is you have a bunch of candidate items and you have a gold standard. And in this case, we use the suicidal ideation questionnaire. And then you statistically model, in this case, 17 items to figure out what is the smallest amount of items you can use to capture the same kids that the gold standard's SIQ would capture. Now, people usually stop me and say, well, if you have a gold standard assessment, why do you have to create a new tool? And that's because the SIQ is a 30-item questionnaire. And we all know that there's no way a triage nurse is going to give a 30-item questionnaire or have time to do that. So we created the Ask. And what we came up with was these 4 questions. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If the patient answers yes to any one of those 4 questions, they're given a 5th acuity question. Are you having thoughts of killing yourself right now? So the Ask psychometrics, what we find, it has good sensitivity, which is the true positive rate, almost 97%. And even probably equally important, it has a good specificity of 87.6%, which is, these are the true negatives. And so this limits false positives. So the ask now has been validated. It started out with the study in the emergency department, but it now has been validated on the inpatient medical surgical unit, in the outpatient primary care and specialty clinics, and it has been validated in adults, medical patients as well. We are also looking at it in schools, in child abuse clinics, in detention facilities. We have some global health initiatives that I'll tell you about in a little bit. We're so excited about our Indian Health Service collaboration. They plan to roll it out in their medical clinics. And as you can see from the slides I presented in the beginning, again, American Indians, Alaska Natives have the highest rates of suicide. And so we're really excited to be screening in those areas. And we're testing the tool in kids with autism spectrum disorder and other neurodevelopmental disorders. The ask has been translated into these 17 different languages. It's free for everybody to use. And we have a toolkit that's mentioned at the bottom here. So let me just tell you a little bit about our inpatient medical surgical study. Again, we use the same 3 hospitals from which the tool was created. And what we found was a 13% screen positive rate. So, and these were kids on inpatient medical surgical units for with medical chief complaints. Now, the rates in the study are probably slightly higher because there's a selection bias of people who want to be in the study. And what it came out, it was very manageable. It came out to about 1 or 2 extra psychiatric consultations per week. I also wanted to highlight our work with Children's Mercy Hospital in Kansas City. And these were the specialty clinics that we looked at. I just want to show you these rates because they're pretty staggering in the diabetes clinic. So this is 29% of those kids screen positive, all the way down to the 0.5%. Now, those are numbers that really warrant us screening all patients for suicide risk. So I guess I'm trying to make a case for universal screening, and I think these numbers really make it. Then our partners at Boston Children's Hospital, they looked at suicide risk screening in the adolescent health clinic, and they found a 14% screen positive rate. And only half the kids had been asked about suicide before. And then there's a study evaluation questions that we asked the kids, and 95% of the kids were in favor of screening in an outpatient primary care setting. So just a little bit about the adult study. It was modeled after the youth study. And this was very unusual because usually in pediatrics, we always have adult tools that we're trying to fit into pediatrics. And that's usually the way that the research goes. But in this case, it was the opposite. We had a tool for pediatrics first, and then we were trying to see if it worked in adults. And so we used these 4 hospitals. We looked at the hospital at NIH, the John Peter Smith Hospital in Fort Worth, Texas, and Rhode Island Hospital, and then Walter Reed National Military Medical Setting. And we had 727 patients on medical surgical units, and these were people over the age of 18. Again, we administered candidate items, and in those candidate items was included the ask, and we looked at the least amount of items that would predict to the adult suicide ideation questionnaire, which is a gold standard. And what we found was that the ask worked. Out of all the items, the ask had very strong psychometrics. So again, this is true positive rate was 100%, so even stronger than the kid tool. Specificity was higher than in the youth, 89%, and a really perfect negative predictive value. So the ask is a valid tool. And this was really important because hospitals didn't want to use 2 different tools. They wanted one tool that will cover youth and adults. And I think what's different about the ask is it was developed specifically for patients in a medical setting. Okay, now I just want to turn my attention to depression screening, because when the Joint Commission put out that Sentinel event alert in 2016, a lot of the hospitals thought, oh, well, we're using the PHQ-9, a depression screen, and we'll just make that our suicide risk screen. And that's probably the same thing, right? And so we were a little skeptical whether or not screening for depression and suicide was the same thing. And actually, So I'm going to use the PHQ-9, and I'm not picking on the PHQ-9. It happens to be a great depression screen. And as Dr. Hogan told you earlier this morning, studies have shown that the PHQ-9 can detect people who eventually died by suicide. One of the issues with that study that he showed you was that 39% of people who said no to that 9th item, the suicide item, actually died by suicide. So that tool missed almost 40% of people. So our thought was maybe screening for depression isn't adequate enough. So the PHQ-9, just to remind you, is a 9-item tool. And this 9th item is, how often have you been bothered by the following symptoms during the past 2 weeks, thought that you would be better off dead or of hurting yourself in some way? Now, the problem with this question is there's 2 problems. One, it has an or in it. And so when someone answers it, you don't know which side of the question they're answering. And it also says hurting instead of killing, which sometimes is an issue because hurting yourself and wanting to kill yourself are 2 different things. There's also been some studies showing that the PHQ-9, the PHQ-2 is not adequate to capture suicide risk. So we actually looked at this and embedded this in our Ask validation study. So these were 600 medical surgical kids when we were validating the Ask on the inpatient medical unit. What we found was 81 of them screened positive for suicide risk. And then 103 screened positive for on the PHQ-A, which is the adolescent version of the PHQ-9. And then 42 screened positive on item 9. And if you put these all together, what you find is had you only screened with the depression screen, you would have missed 1/3 of kids at risk for suicide. And had you only screened with item 9, you would have missed 56% of those kids at risk for suicide. So bottom line of this, I think, is that it's great to screen for depression. If you're going to screen for depression, use a depression screening tool. But if you're going to screen for suicide risk, you need to ask specifically about suicide, and you need to use one of the suicide risk specific tools. Now, there's also people who screen in this manner. They give the PHQ-2, and if those patients screen positive, they give the PHQ-9, and if those patients screen positive, then they give a suicide risk screen. So I will tell you that there is no evidence showing that this is a valid way to screen for suicide risk. I mean, why are we making patients jump through all these hoops when giving something like, for example, the Ask takes 20 seconds to give that tool? And so one of the things that pediatricians told us was, well, we don't want to give 2 different tools. So what we did was we just stuck the Ask on the bottom of the PHQ-9. And so if they wanted 1 sheet of paper, they got 1 sheet of paper. So when we screened for suicide risk when we wanted to reach out to primary care, especially pediatricians, I needed a primary pediatrician superhero, and I got one in Dr. Ted Abernathy. So he's this man right here. And after I gave one of these talks to the American Academy of Pediatrics, he called me and he said, I want to screen in my practice. And he had a very large practice, over 7,000 patients in Richmond, Virginia. And so we observed his quality improvement project of screening. Now, he had that common concern that I know some speakers have spoken about already. And this is the number 1 concern of parents. Like, are you going to put the idea in my kid's head if you ask about suicide? So I'll tell you, there's at least 4 different studies now that have refuted this myth. And in fact, the best way to keep a young person from killing themselves is to ask them directly, are you thinking of killing yourself? And then to listen to the answer and then to get them help. So Dr. Abernathy started this as a quality improvement project. He started with kids 12 and over. Receptionists handed out. And so they hit that concern head on. They said, we're going to screen for suicide risk today because it is a national public health problem. And it is not harmful to your kid to ask about suicide. The Ask was screened by nurses when they were taking vitals. It was scored in real time. And then if somebody screened positive, the physician was notified and they did the next step, which is a brief suicide safety assessment, which I'm going to tell you about in a minute. The Ask now comes with a toolkit. It has the tool in it. It has this brief suicide safety assessment. It has scripts for staff, information for parents, flyers for parents or guardians, and some educational videos. So what's considered a positive screen on the Ask? It's yes to any of 1 through 4. For kids who refuse to answer, we also consider that a non-acute positive screen. And then anyone who screens yes to 1 through 4 gets that 5th acuity question. Are you having thoughts of killing yourself right now? The 2 ways to screen positive. Now I will tell you, because we have some big data from a hospital that screened over 90,000 kids with the ask. And I will tell you that the screen positive rate is around 3%, a little bit higher in the emergency department, maybe 6%. So maybe somewhere around 93, 94, 97% of your patients are going to screen negative when you screen them for suicide risk. Those are patients presenting with medical chief complaints. And then the ones that screen positive, 99.5% are going to screen non-acute positive. So that's not an emergency. That's just a flag that requires further evaluation. And that's when the patient needs a brief suicide safety assessment. The patient is asked to stay until they get their brief suicide safety assessment. But if they want to leave, they should be treated as against medical advice. They should not be forced to stay. And we've talked a lot with Gina and Stacy about this at the Joint Commission, actually, that it would be like if someone had a skyrocketing blood pressure and they didn't want to wait for the cardiologist, right? People wouldn't tackle them in the hallway and make sure they stayed. They would have them sign out against medical advice. The less common way to screen positive is acute positive. That's a yes to question 5. That is urgent. That's an emergency. It's very rare for patients presenting with medical chief complaints to screen acute positive, but it happens once in a while. And that is a need for an emergent evaluation. And it doesn't require the brief suicide safety assessment because we know that person needs full-on safety precautions. That patient should not leave and should not be left alone. And so what I'm talking about is this 3-tiered pathway that actually Dr. Khalid Asfal and Dr. Brombad and Dr. Kurtz are going to speak about tomorrow. But I'll just tell you briefly, it's the brief suicide screen with the ask, and then a brief suicide safety assessment. And then that determines whether or not a patient needs the full mental health evaluation. Now, this is the most important step, is the second step. And that's because hospitals that treat every patient that screens positive uniformly makes the screening program untenable. You really have to have a difference between the non-acute positives and the acute positives. So this is the pathway that they're going to talk about tomorrow. It starts with the ask, again, the brief suicide safety assessment, and that determines whether or not the patient needs full-on safety precautions and what happens next. You can use either something like the CSSRS, the Columbia, to do a brief suicide safety assessment, or you can use the ask brief suicide safety assessment, or you can use something else. We made the ask brief suicide safety assessment because we felt like we wanted to help clinicians operationalize next step. So this is basically what the outpatient one looks like. There's one in the toolkit for youth, there's one for adults, and for every venue it's different. And basically it helps you make 4 choices. Is this imminent risk? Is this an emergency? Is this high risk, meaning they're in the emergency department for a broken ankle, but now they screen positive for suicide? We need to do the psychiatric evaluation today while they're here. Or it's low risk, it's not the business of the day, but they could benefit from an outpatient referral, or no further intervention is necessary. During COVID times, we did adapt the pathway for telehealth. And so on the Toolkit website, we have a COVID-19 telehealth pathway for youth and adults. And basically it highlights avoiding the emergency department, making a safety plan, and helping parents keep their house safe. We do lethal means safe. We have the pediatrician do lethal means safety counseling and make a safety plan in order to avoid exposure in the emergency department and not to overburden the emergency department. The safety plan, very briefly, and you could spend hours on this, right, is helping the patient figure out what their warning signs are, what their personal trigger items are, helping them develop coping strategies. What are you going to do if it's 2 o'clock in the morning and you're thinking of killing yourself? Let's talk about it now so you have a plan. Who are their social contacts? Who are their emergency contacts? And then reduce access to lethal means. And this safety plan is the Stanley Brown safety plan that was mentioned earlier. Lethal means safety counseling, so important. Have to help parents realize that they might have things as benign as Tylenol and Advil in the house, they got to lock those up because those are still pills kids could use to kill themselves. Gun safety, safe storage, all this actually makes a difference. People think, I'll use the example of putting nets under bridges. So skeptics will say, well, if someone wants to kill themselves, they'll pull up to a bridge and there's a net, they'll go to another bridge. Studies show that that's not true. If you thwart someone's plan to kill themselves, you most likely will save their life. Because when people are suicidal, they are in a state, and you need to help distract them and get them through that state because their thinking is not clear. So the toolkit has trainings. We turned the research into practice. The ask is now being given in places around the country. These are some more examples of places that are administering the ask. We have some global initiatives to validate the ask in native languages around the world. And I'm just going to skip ahead because I know I'm running out of time, but this basically says these are just some additional considerations to think about for both adults and pediatrics. You should screen, you should ask the parents to leave the room, but if they don't, it's okay to screen in front of the parents because that's modeling good suicide. How do you talk to kids about suicide? So in summary, medical settings an important venue to identify suicide risk. It can take 20 seconds to screen. It requires practice guidelines in place for managing positive screens. And again, you're going to hear about this 3-tiered clinical pathway tomorrow, and discuss safety planning with families and how to safely store lethal means. So if you'll, I'm going to end with this example from Dr. Abernathy's practice. He was doing well visits to start, and then he eventually moved to sick visits. But what happened was a mother brought in an 18-year-old. She thought he had mono because he was very fatigued. The nurse had an intuition that something wasn't right and administered the ask. And this is how he answered yes to the first 3, no, he'd never done it before. And he was actually one of these rare acute positives. So this was a socially connected kid who had a athletic scholarship to college, and then he was caught in an underage drinking party and was in jeopardy of losing his scholarship. And he had a plan to kill himself the next day. And had this nurse not had a bad feeling and screened him, he would have been, Dr. Abernathy thinks he would have been one of those kids you read about in the newspaper. And so this nurse saved his life by having a bad feeling. So this, I think, is a really good case for universal screening. No one should have to rely on bad feelings. It should just be systematic. So a common concern from pediatricians is, how am I going to manage the extra kids that I'm going to identify when I start screening? And so I'm going to give it to you, and he'll allow me 27 more seconds in Dr. Abernathy's words.
No one deserves to die by suicide. No one. And the one thing that motivated our group more than anything in the world when we started talking about doing this was, it wasn't how many were we going to catch. It was, how are we going to deal with the one that we don't catch? How are we going to handle the death of one of our, which is by suicide? And that we no one.
Big team of people went into the studies and putting this into practice and implementing. I want to thank all of them. And I would love to take your questions.
Thank you so much, Dr. Horowitz. So we've had a number of questions come in, and I'd like to start with a common one, which is there a difference in the validity of the ask if it's handed to the patient to complete, or if a trained healthcare professional asks the questions?
It's a great question. I'm still waiting for somebody to do the study. It's actually done both ways. When we created the ask, we meant it to be verbally administered because we thought there was some value in that. When we've asked kids in our studies, you know, which way would you rather do this? Would you rather write it down or have someone ask you directly? And they're mixed on it. So it's split. So it's actually valid to use in both ways.
Wonderful. We have another question. Christine Walker asks, after thanking you so much for you do for all our kids, about the language that we use around suicide, like getting help and hurting yourself. Are there words that you feel are more helpful and less helpful when we're talking about suicide?
Um, so I am a big believer in from our research, I'm a big believer in being as direct as possible. So I think um, when we trained nurses to do this, a lot of nurses were very uncomfortable with the direct language of it. But then after they started doing it, they became more comfortable. And kids, I actually remember from the very first study we ever did, and I was in the room with a child who presented to the emergency department with psychiatric issues. And I asked him, because this was our study, so I asked him every which way come Sunday about suicide, except I didn't say it directly. And at the end, I said, is there anything else you want to tell me that I could have done better here? And he looked at me and he said, you should have just asked me if I was suicidal. And I thought that was so great because, it's hard to say to somebody, are you thinking of killing yourself? That's not an easy thing to say. So I would say to people to practice it, but then just hit it straight on. I also want to use this opportunity to say something, I know we talk about kids 12 and older, but really the ask is what we recommend is starting at age 10 and older. And it's because of that CDC slide I showed you that said 10 to 12-year-olds are really the highest rate of growing, the highest rate of increase right now. They're not the highest rate, but they're increasing. And it's okay to ask 10-year-olds. And patients presenting with psychiatric chief complaints, we suggest you start at age 8. And the precursor to ask was actually tested in 8-year-olds. So there is a screening tool that was tested in 8 and 9-year-olds. It's embedded into the ask. So I feel comfortable that the ask can be given to kids 8 and above. Below age 8 is very tricky. I would not universally screen 7 and 6 and 5-year-olds. What I would do is that if you're a healthcare provider and there's definitely 6, 7, and 8-year-olds who are engaging in suicidal behavior. It's rare, but it happens. If you suspect it, you should assess them. You don't have to universally screen them. You literally just talk to them about it. So I hope that answers your question.
Yeah, thank you. Dr. Jensen is wondering if you have any ideas about what is prompting this dramatic increase in suicide deaths in preteen kids, particularly in minority preteen kids.
Yeah, you know what? We really don't have the answer to that. We know that there's a lot of stressors that are increasing, and that that the mental health picture for kids is not looking good. There's not enough access to mental health care. There's stressors on their families. One thing we find is parents with mental illness. There's studies now showing that if you treat the parents for their mental illness, the kids who are also struggling get better, even in absence of treating the kids. So there's, a lot of adults who are under stress with unemployment and financial stressors. And, there's just a tremendous amount of stressors. We don't know why these rates are going up so much for the young people.
Okay. Let's see. Rebecca Feinstein says, we have an issue with teens in our programs that it takes a few levels of screening or multiple screening in order to endorse the suicide questions.
I wonder if that's the tiered approach that some people use that I actually I can't find evidence that that's valid. I really believe that the healthcare providers need to just ask directly about suicide and not wait for the patient to screen positive on a depression screen and then just screen those patients. What we are finding is that this is no longer theoretical. There's hospitals, I told you about the hospital in Dallas, Parkland Hospital. They screened over 90,000. Now they've screened over 100,000 kids with the ask. It is not overburdening their system. They are not, emergency departments who are screening, Boston Children's Hospital, Nationwide Children's Hospital. They're not, they're not increasing their borders that are in the emergency department for mental health issues. This is, picking up a few kids who are at risk. And when you pick someone up, it could save their life. So it matters.
All right. Well, I'd like to thank you so much for your time and for your really a presentation that I hope inspires us all to see that universal screening for suicide is possible and essential.
Okay, thank you so much.